دكتور محمد رشدي هيقدم لنا حالة دايريا وست تايب 1 diabetes.
بسم الله الرحمن الرحيم. A rare case presentation from Asyut University Hospital, a case of type 1 diabetes and chronic diarrhea. A 38-year-old male with history of insulin-dependent diabetes mellitus for 20 years on basal bolus insulin therapy, 60 units per day. There is a history of transsphenoidal hypophysectomy due to a non-functioning pituitary adenoma of 5 years duration, as it was causing him pressure symptoms. After operation, the patient developed hypothyroidism and hypoadrenalism, and so he was prescribed thyroxine and prednisolone orally. The patient presented to the ER by diarrhea of 2 months duration, chronic diarrhea, described as 7 motions per day, large volume, watery inconsistency, without blood or mucus, associated with loss of appetite, vomiting, nausea, and weight loss of 13 kilograms. There was no history of fever or foreign travel, no history of laxative use or association with specific foods, and the patient denied alcohol consumption. On admission, he was severely dehydrated, not feverish, pulse 100 beats per minute, blood pressure 110/70 with orthostatic hypotension, and he has a low body mass index of 18.3 kilograms per meter square. There was no rashes, and otherwise he has the normal physical examination. These are the classifications of chronic diarrhea. There is osmotic, secretory, malabsorptive, hypermotility, and inflammatory causes. This patient case correlates with a secretory type of diarrhea, water inconsistency, high volume, not relieved by fasting, and it has nocturnal bowel motions. The past history and family history were non-significant. There is no history of allergy as well. Initial laboratory investigations show that this patient has recurrent attacks of hypoglycemia, metabolic acidosis with negative acetone, mostly normal anion gap metabolic acidosis due to chronic diarrhea, microcytic hypochromic anemia, hypokalemia, hypomagnesemia, hypocalcemia, and hypoalbuminemia, and these all point to a severe state of malnutrition and malabsorption. The differential diagnosis for a case of chronic diarrhea in diabetic patients include the adverse effects of anti-diabetic medications, dietary intake of osmotic substance like sorbitol and mannitol, celiac disease, pancreatic exocrine insufficiency, small intestinal bacterial overgrowth, diarrhea predominant irritable bowel syndrome, inflammatory bowel disease, microscopic colitis, hyperthyroidism in this case could be iatrogenic, excessive alcohol consumption, laxative abuse, and the neuroendocrine tumors like piboma, somatostatinoma, and glucagonoma, and MIN syndrome type 1, and adrenal insufficiency. Initial management for this patient included dextrose 25%, intravenous fluids, and electrolyte replacement, and due to the severity, he was prescribed empirical antibiotic therapies with ciprofloxacin and metronidazole. But despite the initial management, the patient experienced recurrent attack of hypoglycemia, which required halving his dose of insulin to 30 units per day, and there was no improvement in electrolyte disturbance and diarrhea. Further investigations showed the stool analysis confirmed the watery consistency of his diarrhea, and there was no white blood cells or ova or trophocyte, no signs of inflammation or infection. Thyroid function test, the TSH less than half, and T3 and T4 within normal, which correlates with non-thyroidal illness. Cortisol level at morning within normal, parathyroid hormone normal, HIV and viral hepatitis negative. Levels of glucagon, somatostatin, and VIV were non-available. Imaging showed normal findings, whether by abdominal ultrasound and abdominal CT. After gathering all this data, we can now narrow down the diagnosis. Some of these diagnoses have become unlikely. This patient has insulin-dependent type 2, type 1 insulin-dependent diabetes mellitus, and so there is no intake of metformin or other oral hypoglycemics, no intake of sorbitol or mannitol or osmotic substance, and this does not correlate with his watery diarrhea. Pancreatic exocrine insufficiency and small intestinal overgrowth is also unlikely, because this would cause malabsorptive or fatty diarrhea, not watery diarrhea. Diarrhea predominant irritable bowel syndrome is also unlikely, because it will not cause this severe symptoms of anemia and electrolyte disturbance. His thyroid function does not correlate with hyperthyroidism. There was no intake of alcohol or laxative, and the patient had hypocalcemia and normal parathyroid hormone, so he cannot be diagnosed as min type 1, and normal morning cortisol level exclude adrenal insufficiency. So we are left with celiac disease, inflammatory bowel disease, microscopic colitis, and endocrine tumors, neuroendocrine tumors. Serological testing for celiac disease came as follows. Serum IgA anti-endomysial antibody was negative. Tissue transglutaminase antibody was negative, but the total IgA was low. Although these tests are negative, but it's not conclusive and cannot rule out celiac disease. Because according to the American Gastroenterology Association, IgA deficiency is an infrequent but important explanation for why patients with celiac disease may be negative on IgA isotype testing despite strong suspicion. In these cases, we need to measure the IgG level and the tissue transglutaminase 2 IgG and the total IgA level. يعني ده الالجوريزم ده بيشرح الدايجنوزس. احنا في الاول المفروض بنقيس الانتي تيشو ترانسجلوتامينيز اي جي اي. لو بوزيتيف وكان التتر بتاعه اكتر من 10 اضعاف النورمال الابر ليميت اوف نورمال بنعمل الاندوميزيال انتي بودي اي جي اي. لو بوزيتيف يبقى كونفيرم الدايجنوزس اوف سيلياك ديزيز. لكن لو الاندوميزيال انتي بودي كان نيجاتيف يبقى البيشنت بروسيد تو بايوبسي. ولو التيشو ترانسجلوتامينيز اي جي اي كان بوزيتيف بس اقل من 10 اضعاف الابر ليميت اوف نورمال برضو diagnosis needs to be confirmed by biopsy. If like in this patient anti-tissue transglutaminase IgA was negative, we need to measure the total IgA level. If the total IgA was low, this is the case of total IgA deficiency. In this case, we need to do other serological markers like transglutaminase IgG, DGB IgG, or endomysial antibody IgG. If one of these is positive, this patient need to confirm diagnosis with biopsy. But if the total IgA is normal, this can exclude the diagnosis of celiac disease. This patient proceeded to our endoscopy, and the macroscopic findings showed pale atrophic gastric mucosa and atrophic appearance of the duodenum, and multiple biopsies was taken. This correlates with celiac disease. Colonoscopy showed no abnormal finding and excluded associated IBD, and AUS endoscopic ultrasound was normal and excluded neuroendocrine tumors. The histopathology findings revealed the marked villous atrophy of the duodenal mucosa and the lymphocytic infiltration. Lamina propria showed chronic lymphocytic infiltration. These findings all confirm this patient had celiac disease. So a diagnosis of celiac disease now has been established. Celiac crisis is a life-threatening syndrome where celiac disease causes acute dramatic metabolic derangements For diagnosis of celiac crisis, patient need to have rapid progression of the gastrointestinal symptoms which require hospitalization or parenteral nutrition, and at least 2 of the following criteria: signs of severe dehydration, including hemodynamic instability or orthostatic hypotension, neurologic dysfunction, renal dysfunction, metabolic acidosis, hypoproteinemia, abnormal electrolytes, including hyponatremia, hypocalcemia, hypokalemia, or hypomagnesemia, and weight loss of more than 10 pounds. Management is through a gluten-free diet. Basically, the patient should replace foods which contain gluten with other foods which are naturally gluten-free. Foods that contain gluten protein include wheat, oats, barley, and rye. These should be replaced with rice, potatoes, lentils, and corn. On follow-up, after 2 weeks, this patient showed dramatic response. His diarrhea stopped, and there was improvement in electrolyte levels. Thank you.